Okay, yeah, thank you. Yeah, thanks.
Excellent. Well, good afternoon and Happy New Year, everyone. Thank you for making it in person on a cold but sunny day. It is my pleasure to introduce Dr. Megan Prochaska, who is an assistant professor of medicine in the section of nephrology at the University of Chicago. This is the season when we highlight local experts because it's hard to get people to come to Chicago in January and February. So Dr. Prochaska completed her undergrad and medical education at the University of Chicago, followed by residency training at the same institution, so really committed to University of Chicago. But then, for some change, she pursued nephrology fellowship training at the combined Brigham and Women's Hospital and Mass General Hospital fellowship program. She also obtained her master's in public health at the Harvard T.H. Chan School of Public Health, and that's where she began her career as an investigator focused on kidney stones. Since then, she has become a nationally recognized expert in this area. Her research, as she'll tell us today, focuses on the mechanisms underlying nephrolithiasis and strategies for prevention, with a particular emphasis on metabolic and dietary factors. She has published extensively in leading journals, has authored a number of book chapters, and contributed to clinical guidelines. Her work has been supported by multiple NIH grants, including a K23 Career Development Award and a very recent R01, which focuses on novel approaches to calcium phosphate stone prevention. And she's currently developing yet another idea for a second R01 on this topic. In addition to her research, Dr. Prochaska is very committed to education, mentorship, and she is very involved with medical students, residents, and fellows. She has many service contributions. She directs the Nephrology Research Conference, and she recently was a chair of the planning committee for the FredCo Symposium that took place last fall. I attended that meeting, and that was an incredibly well-organized meeting that brought together leaders in kidney stone research and clinical care from throughout the country who participated in this very well-organized symposium. She's also on the planning committee for an international conference on stones, and she reviews many grants and manuscripts. Besides these contributions are many clinical contributions, and these have been recognized by awards such as the Outstanding Clinical Service Award from University of Chicago Department of Medicine. So without further ado, I will give it over to Dr. Megan Prochaska. Thank you very much.
Thank you. Thank you. Thank you so much for the wonderful introduction, and also, of course, for the invitation and the opportunity to speak here. Yes, it is cold, but as you picked up, I'm a Chicagoan, so I do love the Chicago Januaries. So what I'm going to talk about today is, I just titled it "Updates in Kidney Stones" because I'm really going to do a deeper dive in terms of two areas of research that our group's been focusing in recently in the last couple of years, specifically sugar intake and then some insulin resistance. So there we go. Okay, perfect. All right, so I'll review some of the basic epidemiology of stones to sort of set the stage, and also review just in general. And for those of you who don't spend as much time thinking about kidney stones, it'll kind of establish a few basics for you. And review diet and kidney stones, specifically, as I said, a deeper intake in terms of sugar, and then we'll make a transition to talking about insulin resistance. Okay. So in terms of the epidemiology of stones, kidney stones are quite common. And when you compare the most recent prevalence estimates, which were greater than 10% in the United States, when you go back to the 90s, this number was more like 3 to 5%, like 8 to 9% about 15 years ago. So each time it's been estimated, it's been on the rise. Historically, this was thought to be more of a condition of men, specifically white men. But with each of these estimates, unfortunately, especially the last time, white men sort of stayed about the same, but women and non-white populations are unfortunately kind of catching up. So that's been a little bit of the more recent increase in terms of the prevalence. Recurrence rates are also quite high. As many as 50% of patients will have a repeat event, and usually they recur pretty quickly. Within 5 years, they'll have another event. Kidney stones are also very costly, estimated about $10 billion annually. And much of this is going to be emergency department visits, operating room costs, obviously two of the most expensive things we do in healthcare. But there's also a pretty big individual financial burden in the sense that patients, if they're in the ER, they're at risk for lost work wages, as well as high copays and healthcare related bills. So hopefully this room well appreciates the message that I usually try to make clear every single time I talk about stones, but stones are preventable. And so, of course, my motivations in terms of preventing them are several. Of course, with one of the number one being that stones are painful and it's really scary for patients, particularly the first time, to have gross hematuria. So, of course, we're trying to reduce some of the acute morbidity associated with stones. But as I'll talk about later in the talk, our kidney stone patients also are at higher risk for a number of chronic medical conditions, hypertension, CAD example. And so ideally, by preventing stones, we can also try to help mitigate risk for some of those conditions in our individual patients. And of course, I mentioned both the overall healthcare costs, but also some of the individual financial burden. And if we can reduce this as well, of course, there'd be benefit. So as a quick reminder, here I have the top panel is men and women. Calcium oxalate stones continue to be the most common stone type for men. This is across, of course, the decades of life. And but for men, as they get to be in their 50s and beyond, uric acid stones become more common, and so overtake calcium phosphate is the second most common stone type. For women, calcium oxalate stones are the most common throughout most decades of life, except for younger women in their 20s and 30s, where calcium phosphate stones briefly overtake them, calcium oxalate stones. And that's because young women tend to have physiologically higher urinary pHs, and calcium phosphate stones are more likely to form in more alkaline urine. Okay, so a little bit more background before we do our deeper dive. There's a number of important common clinical risk factors for developing stones that have been well described. So, I mentioned it having the recurrence rate. So a personal history of stones, of course, increases your rates. Family history of stones is also quite important, about 50% of an increase if you have a family member who has a stone. And I'll just quickly say in terms of the genetics, for a long time, we've well understood a lot of the monogenic causes of kidney stones, cystinuria, for example. And in the last couple of years, there's been a much greater understanding and more accountable for the heritability of stones from some of these GWAS studies and polygenic risk scores that are coming out. Still a lot more work that needs to be done there, but certainly, many of our patients have idiopathic hypercalciuria and seems to have a familial link. And in the last couple of years, some of the genetic studies have done a better job accounting for some of that heritability. Okay. Also, there are a number of important systemic conditions that increase risk of stones. So these are going to be things like, conditions that increase the enteric absorption of oxalate, like IBD, pancreatic insufficiency. Systemic conditions like obesity, diabetes, gout, hypertension are all really strong risk factors for developing stones. And dietary risk factors. So I'll briefly touch on the data regarding sodium, calcium, protein, and then we'll do the deeper dive in terms of sugar intake. But also, as I mentioned on the previous slide, our patients who have kidney stones are subsequently at higher risk for a number of other chronic conditions: bone fracture and osteoporosis, hypertension, CAD, CKD, and ESRD, as well as diabetes. And in the second part of the talk, we'll go a little bit more into some of those details, specifically as it relates to diabetes and insulin resistance. Okay. But first we'll go through the dietary risk factors. So high kidney stone diet increases kidney stone risk. This has, been well established for a number of years, and I really like this figure. It's not published, but it's publicly available on Dr. Koh's website. Fred Koh is one of my mentors, and what it represents is in red. This is all the different dots and triangles are different trials and observational studies of non-kidney stone patients, and you can see here that for the non-kidney stone group of patients, higher urinary sodium, which of course would occur during higher dietary sodium intake, is associated with then having a higher urinary calcium level. And in blue is the same thing with kidney stone patients. So different trials and clinical studies, observational studies are represented with the dots and the triangles. And so that the association between high sodium and high calcium is even more exaggerated for these patients. So for the same level of dietary sodium and therefore urinary sodium, these individuals have a really high urinary calcium level. And I'll also highlight that this figure, because each dot is a single study, this actually represents hundreds of individuals. And so there's a lot of data that's represented in this figure. And so when I see a patient who has high urinary calcium levels, one of the next numbers that, of course, I look at is their urinary sodium level. And if I find someone who's up here, then I spend a lot of time in clinic really counseling and educating the patient, finding strategies to lower that dietary sodium intake so I can bring them down here in terms of their urinary calcium levels. And consistent with this is the fact that, from an epidemiologic standpoint, the Mediterranean diet, the DASH diet, these are both dietary patterns that are associated with lower kidney stone risk. Okay. We also know that high protein diet increases stone risk. And this is in part because high protein diet also increases urinary calcium. For a while, it was thought that this increase in urinary calcium was related to bone buffering because, of course, high protein diet is going to increase an acid load. And if this is buffered by the bones, that will release more calcium, increase filtered load of calcium, and subsequently then increase calcium excretion. But a nice study from about 15 years ago from UT Southwestern, they put people on, as you can see, a couple of different diets, including a high protein diet with potassium citrate, so to neutralize some of that acid. And you can see that the urinary calcium levels are still elevated in that group. So probably a different mechanism. We do know that urine calcium levels are high, but what exactly the mechanism is not completely worked out. But because of the acid load, these patients are, of course, going to have lower pH, lower citrate, and then also potentially lower urinary potassium. And, it's interesting. At ASN, I gave a talk where I briefly touched on this. And at the time, I've been seeing really high protein takes increasing. In the last year, I've seen a number of, particularly actually young men in their 20s and 30s, coming in with very, very high protein intakes. And when I sort of tell them you're eating a lot of protein, they give me a little pushback because actually every single one has said the same thing. Well, on TikTok, I saw that you should be eating literally they're saying 200 grams of protein per day, like really, really high amounts that you can really only achieve with supplements. Or I can only imagine that you would need some supplements to achieve that. And so we're seeing this a lot more because of that wave, but also as many of you may know, the USDA recommendations for protein intake previously were 0.8 grams per kilo, and that's actually gone up pretty dramatically with the most recent change. And so changes in guidelines up to, I think it was like 1.2 to 1.6. So we're going to see, I don't know, it'd be interesting to me to see how we might start seeing this a little bit more. In general, with my kidney stone patients, I usually say about 1. It's usually easy for them to do the math. If I say 1 gram per kilo is usually adequate in terms of adequate amount of protein intake, but also not too much of an acid load and otherwise stress to increase urinary calcium. Okay. And so also, hopefully this is very well appreciated by this room, but I still, even though we now have over 30 years of data showing that lower dietary calcium intake increases stone risk, I still probably at least once a year, sometimes, even more than that, sometimes have a patient who comes in to say, oh, I found out I had a calcium stone, and what I've done so far is lower my dietary calcium intake, which of course makes me, pause and really want to spend some extra time with them counseling, because we know that low dietary calcium intake is actually detrimental. So to show that and kind of quantify it, you can see here, this is data from the Mayo Clinic. We have predicted probability of stone formation on the y-axis here and dietary calcium intake on the x-axis. And you can see here around 1,000 to 1,200 milligrams per day, which is our recommended intake, is the sweet spot in terms of a reduction in stone risk. Much higher than that, which also you probably need some supplements to get to, like 3,000 is also, that's a lot of cottage cheese if it's not in supplement form. Is probably stone risk is higher in this group because you can increase urinary calcium in this setting with really high calcium intakes. But this portion of the curve where calcium intake is actually low is the increased risk there is driven because of increases in urinary oxalate. And that's, of course, because we know that if you're on a low calcium diet, you absorb more of your dietary oxalate. To demonstrate that, here we have the percent of oxalate that's absorbed in the gut Again, calcium intake is on the x-axis. And you can see here is that same sweet spot of around 1,000 to 1,200 milligrams per day of dietary calcium is where you're going to absorb less of your oxalate. Because if you consume the oxalate and the calcium together, of course, they're going to complex in the gut, and that free oxalate will not be absorbed. Whereas without the calcium there, that oxalate is really readily absorbed. Okay. And also, we can get concerned about a low calcium diet, as we know that our kidney stone patients are already at risk for bone disease, low bone density, probably related to urinary calcium levels. And if we put someone on a low calcium diet, we're increasing the risk that we're exaggerating or potentially exaggerating their negative calcium balance. And of course, then that puts us at concern for bone disease risk. Okay. And of course, this is where we have nice randomized controlled trial data as well. This is the Borhe diet trial that now is about 20 years old. But what they did is put people on a low calcium diet and then a normal calcium diet of 1,200 milligrams. They also set the sodium and the protein content for that, for the normal calcium diet arm. Oxalate intakes were similar between the two groups. And, so here we have incidence of recurrence on the y-axis, and then, of course, time on the x-axis. And you can see here that right about 36 months or the 3-year mark is really where these two curves begin to split. And with the low calcium arm having a much higher incidence of recurrence. And I think kind of two takeaways from this. The first is that then also when they showed then the 24-hour urine composition and the differences between the two groups, really the most prominent difference between the two groups was that the normal calcium arm had lower urinary oxalate. So sort of consistent with the physiology that I was mentioning before. And the other side is more of a study design concept, in the sense that had we just stopped the trial at 3 years, we might not have seen this nice split. So we see this a lot, of course, in nephrology in terms of our outcomes, but long trials are expensive. And so either getting really good solid surrogate markers or making sure we can do the full trial is really important, because, had we stopped it here, I might be like, it doesn't matter how much calcium intake you have, or I would have had to base it at least on the observational and other epidemiologic studies. Okay. All right. So with that, let's talk about sugar intake as promised. So we know that high sugar intake is associated with higher kidney stone risk. This is data. The top panel is on sucrose. The lower one, or the lower table, is looking at total fructose. So two different types of sugar. Both of these are taken from HPFS, Health Professional Follow-Up Study, is a male cohort. The Nurses Health Studies 1 and 2 are both female cohorts. And you can see here the highest quintile of sucrose intake right here that's circled is associated, compared to the referent of the lowest quintile group, is associated with a much higher risk of stones. The relative risk there in the multivariate model was 1.31. And similarly down here for the 3 cohorts, but separated, the multivariate relative risk for the highest quintile of total fructose intake is 1.37, 1.35, 1.27, to give you a sense of the magnitude of the risk. Okay, so the question, of course, is why? What are the mechanisms? What's driving stone risk for people who consume higher amounts of these sugars? Well, the thought is it's probably related to calcium homeostasis and calcium handling. So this data goes back to the 1960s, 1970s. Jack Lemmon, among other folks who were interested in this at the time. This study is from Jack Lemmon's New England Journal paper in the late 60s. And what they did is they gave either glucose or sucrose to these 3 different groups: the non-kidney stone patients, calcium kidney stone patients, and then the relatives of those individuals. And you can see here across the board, every single group, even though they're given a mononutrient of glucose or sucrose, and their urine calcium goes up. So they also found that it wasn't just calcium that goes up. Magnesium also goes up, and that's shown here. And then they further went another step and said, okay, well, is this an effect of an increase in filtered load, or is this a difference in terms of something that's happening at the level of the nephron? So to get a better sense of that, they had people actually stand and consume the glucose. And what that did was, you can see here that the filtered load of calcium actually goes down with standing. So the filtered load goes down, and yet the calcium excretion still goes up. And so this is not a filtered load effect, but instead something that's happening in the level of the nephron. So we decided to follow this up more recently, a couple of years ago, to the same concept in terms of the study design, but with a few more tools to see if we could further narrow where is this happening in the nephron and what's the mechanism behind this. So what we did is we brought in, these were non-kidney stone patients. We had 6 of them who we brought in, and we gave them glucola. So they came in first to our clinical research center. We collected 3 fasting bloods with urines and then gave them the glucola. And then you can see these are then, so the negative one here represents the mean of their baseline, their 3 baseline before they consume the glucola. We gave them the glucola right here. And then periods 1 through 6 represent then timed spot urines that were collected every 30 minutes after the glucola. When the period was starred, that's when that individual period was statistically higher than baseline using a mixed effects model. And so, of course, the glucose, not surprisingly, rises right after the glucola administration, comes back down and remains above baseline until period 5. And similarly, serum insulin rises quite quickly, remains above baseline before then coming back down. And similar to what was seen by in the older studies, we see the fractional excretion of calcium also goes up. They didn't consume anything else, just the glucola. And the fractional excretion of calcium is above baseline for periods 2 and 3. And then magnesium also rose and was above baseline for periods 2, 3, and then 4 as well, before both of them, of course, coming back down. One of the things we were able to add that the older studies did not do, because a PTH assay is more readily available now, is we checked PTH. So you can see here that the PTH actually drops right away and is below baseline for periods 1 and 2 before coming back up. But there was no difference in fractional excretion of sodium throughout the duration of the study. They were instructed to be on a low sodium diet for 3 days leading into doing this. So in general, the fractional excretions of sodium were on the lowish side. Okay, and the last piece that we added was looking at urinary exosomes. So one of the members of my team has done some work in urinary exosomes. So he was the one who did this part of the study for us. But what we're looking at is the microvesicular vessels of these different transporters and looking at abundance. And I think it's one of the criticisms of at least this part, which is a very reasonable and appropriate criticism, is that this is looking at abundance, and abundance does not necessarily mean activity, but still is at least a marker about thinking about what's occurring with some of these transporters in the different sections of the nephron. You can see, of course, there was no difference in NHE3, the more proximal transporter, NKCC2 in the thick ascending limb, also no difference pre versus post glucola. NCC, similar. But we did see with TRPV5, of course, the calcium the calcium transporter in the distal convoluted tubule, that the variability was much wider post-glucose, but in the overall, the mean abundance was lower. Okay, so we replicated the mononutrient of glucose being able to raise urine calcium, and we added to it that also PTH decreases and mean abundance of TRPV5 decreased. So for us, what this really meant is we already thought it was probably occurring in the nephron. And I think that this further sort of narrows the portion of the nephron where this effect is happening is probably more distally, potentially in the thick ascending limb, given the effect of magnesium as well. That's in terms of this, probably as far as we can add. In terms of what other hypotheses do I have in terms of what's going on here? There was a couple of years ago some work out of Japan, I think it was, where they showed that glucose is an allosteric modulator to the calcium sensing receptor. And if their hypothesis is true, potentially this could explain much of what we're seeing. We know that the calcium sensing receptor is in the thick ascending limb, so potentially that has some effect in terms of the calcium and magnesium reabsorption. Also, given the changes, the decrease in the PTH and therefore then the decrease in TRPV5, potentially this is also an effect of that. That's completely hypothesis. That has not been looked at. And of course, we can't say anything about that in the data that we have. But as I think about other ways and sort of next steps for this, that is one thing that is in my mind to consider. But the other thing you might be thinking is, what about insulin? The insulin goes up too. Why am I focusing on this being a calcium or a glucose effect? Is this from the insulin? And what makes me say probably less likely to be an insulin effect is this data here. So this is from UT Southwestern. And what they did is they used a hyperinsulinemic euglycemic clamp. And for all 3 of these groups, you can see here that non-stone formers that are lean and obese, and then also stone formers with idiopathic hypercalciuria. And the fractional excretion of calcium, didn't really dramatically change both on, off, or on clamp, and was not dramatically different between these three groups. So probably less likely insulin, although still potentially an important part of the story to be considered with future work. Okay, so some of you may be wondering about chronic sugar intake. And I know at one point John Asplin was, because part of the motivation for doing this study was actually John, who is of course sitting up there, who asked me, when I was presenting some of this data at our Rock Society meeting a couple years ago, he said, well, what about chronic sugar intake? We don't just consume glucola, right? We consume dietary patterns, and some people have dietary patterns that are higher in some of these sugars than not. So I thought one of the best ways to take a look at this was looking at data, again, from the cohorts I'd mentioned previously, the HPFS Nurses Health Study 1 and 2, a male cohort and 2 female cohorts. Because in those cohorts, there's now almost 6,500 of the participants from those cohorts have completed 24-hour urine collections. And they also routinely and regularly complete food frequency questionnaires, which of course are well-validated tools for longer term, on the order of months of food intake in both macro and micronutrients. And so I had, this number of 6,500 or almost 24-hour urine collections with food frequency questionnaires that were timed at the same time. So the tables for this paper are a bit robust in terms of lots of numbers. So I just took a kind of a portion of it to show with you here, so you could see who the people were for this part of the study. You can see here that the HPFS, mid 60s, similar for nurses 1, the individuals were in their mid 60s at the time of the urine collection. And then nurses 2 is a little bit of a younger cohort. And you can see that here, more mid 50s. Across the board, their BMIs were kind of in the 25 to 28 range. Okay, so then what I did is I did some multivariate model looking at the different quintiles for these 3 different sugar intakes. So free fructose, total fructose, and sucrose. Total fructose is the sum of the free fructose plus 1/2 of the sucrose, and that's because sucrose is a disaccharide of fructose and glucose. So that's what the difference between these 2 columns are. And so what I'm just showing here is quintile 5. Of course, quintile 5 is in reference to quintile 1, and then the P for trend is across all of the quintiles. But you can see here that for all 3 sugars, the 24-hour urinary calcium was actually lower. Magnesium was also lower. FAS was lower. pH was a touch higher, and the volume was also a touch lower. And so as a result, there's probably because of the change in volume, the calcium oxalate and calcium phosphate supersaturations were, a little bit mixed in terms of the results, but a little bit, if anything, on the higher side, particularly for sucrose, but also slightly for fructose as well. Okay, so of course, this was the opposite of my hypothesis. I came in thinking that, I'm going to see that the calcium was higher because that's what I saw with the acute. That's what I would expect. And then when the output came and said lower, I spent some time trying to figure out how I had messed it up, and figured, when I really double checked it multiple times, realized, no, this was in fact the real result. So we saw the opposite of what I saw in the acute glucola study. And I don't show it here, but there was no differences between stone formers and non-stone formers in that epidemiologic study. So I have to come to terms with the fact that the results are different between the higher urinary calcium acutely, but chronically lower urinary calcium. One explanation that potentially could account for, or at least I need to acknowledge up front, that could maybe contribute to some of the discrepancy, is the fact that the chronic study was looking at 24-hour urine collections. So this is not going to reflect the postprandial spikes, for example. If someone has a sugary breakfast, if they have, a donut for breakfast, I'm not going to see that their urine calcium, if their urinary calcium comes up and comes back down, I'm just going to see the overall 24-hour excretion. And so potentially, for example, in my glucola study, maybe had I continued to monitor for a few more hours, maybe I would have seen that the urinary calcium continued to go down below baseline. I don't know. I didn't do it, so I have no idea. But that could be at least accounting for some of the differences. And similarly, I have to come to terms with the fact that in these same cohorts with these exact same exposures, urinary the higher intakes of both fructose and sucrose were associated with higher risk of stones. And I thought it was going to be because higher calcium, then therefore higher supersaturation, higher risk. But of course, that's not what I saw. Potentially, this is still an issue with 24-hour urine collections not capturing spikes. Similarly, if you have a spike in calcium and supersaturation and you form a bunch of crystals during that time, even if your calcium comes back down in the subsequent couple of hours, if you formed crystals, that still could put you at risk for a stone. Of course, I can't say what is occurring. These are just some of my hypotheses and potential explanations. But certainly, I think that because is as frustrating in some ways it was to see the opposite of what my hypothesis was, it also is an opportunity to think about, well, why? And so I don't have that study designed yet, but of course, this is something that I'm thinking about. And some of you might say, okay, well, maybe it can help us put it together if we think about what happens more subacutely, just on the order of a few weeks. The only study that I've found that really did that was this study that was published about 35 years ago, also from the folks down at UT Southwestern. This includes 16 men. None of them were kidney stone patients, and half of them, 8 of them, had insulin-dependent diabetes. And you can see that for each of these men, they put them on these 3 different dietary patterns: high fat for 2 weeks, and then high complex carb, high simple carb. They did not put the diabetic patients on the high simple carb diet. But across the board, though, there's no big difference in terms of urinary calcium levels. And so, still, I think the conclusions from all of this is that we certainly need more work to be done. The part of the potential hypothesis and explanations that I didn't include earlier that we've pondered as we've tried to understand the differences in terms of the results for these 2 different studies that I've done. I was thinking about the effects of bone. So certainly there may be a bone contributing in some ways, cellular shift contributing in some ways that we're certainly not in the studies I showed you accounting for quite yet, that in future studies we're definitely going to want to consider. I think that I think it's important because mechanistically, I think it'd be really helpful for us to better understand. But also there is some clinical relevance because my patients will absolutely ask me, well, how much sugar should I have? And I can't quantify it. I mean, I can quantify things like volume and sodium and calcium. I can quantify some of these other dietary components, but I can't really quantify this. So I sort of say, lower is better and don't have sugary drinks. But I do think it would be helpful for me to be able to better counsel them if we have more information and more understanding of the underlying mechanisms driving this. And so certainly something I'm interested in and thinking about ways we can, that we can further study this. Okay. But with that, I'm going to make a switch, though, to talking about calcium kidney stones and insulin resistance. Okay. So at the start of this, I told you about how kidney stone patients are also at risk for other chronic medical conditions, subsequently developing other chronic medical conditions like bone disease and coronary artery disease. And also on there, of course, is diabetes. Diabetes is interesting, though, because, of course, it's also on that upper list. So what I'm saying here is that diabetes is a really strong risk factor for developing kidney stones. But the opposite association is also true. Patients who have kidney stones are at higher risk for developing diabetes. And so appropriately, much of the effort and attention has been provided to, or really been paid on that first association, the first direction of the association. And this is because diabetes, obesity, higher waist circumference are some of the strongest risk factors that we have for developing kidney stones. Much of this is related to uric acid kidney stones, not completely, but much of it is uric acid kidney stones. And this is because metabolic syndrome lowers our urinary pHs. So for example, here we can see that the multivariate adjusted 24-hour urine pH, if you look then at the number of the features of metabolic syndrome, as the number of features rises, of course, the urinary pH goes down. And this is thought to be because metabolic syndrome is associated with impaired ammoniogenesis. And so these individuals don't increase their ammonia to the same acid load. And of course, then they're going to lower their urinary pHs if they don't have that same buffering capability from impaired ammoniogenesis. And so with those low urine pHs, of course, then they're going to be more at risk for forming uric acid stones. But I will also say, that these patients still form a whole lot of calcium stones. It's just they also, much of this physiology is occurring for them. However, so this is where a lot of the prior work has been. But the opposite association is also true, that our patients who have kidney stones are at higher risk for developing metabolic syndrome, diabetes, cardiovascular disease. Of course, I do need to acknowledge up front that these epidemiologic studies are challenging to do because the date of diagnosis for something like diabetes, of course, is not probably the same date of when disease onset was, right? So patients who with metabolic syndrome, diabetes, they can go many years from the date of onset of the condition before they're actually diagnosed. So it does make these epidemiologic studies challenging. But with that being said, this has been shown time and time again. There's multiple studies that have shown this. And this is one example, at least from the cardiovascular side of things. This is data from Alberta, so the group in Calgary. You can see here that higher risk of MI, acute MI, higher risk of CABG, stroke, and all cardiovascular events in the stone groups compared to the non-kidney stone patients. Okay. So with that being said, we also wanted to sort of do a deeper dive of this in terms of some of our data. So before I go through the results of this study, I'll give you a little bit of background as to where I got this data that for the study I'm going to show. For about 20 years, my mentors at the U of C, Dr. Coe, Dr. Worcester, they were running a clinical research center project, their PPG protocol essentially, where what they did was they brought kidney stone patients in and control, not otherwise completely healthy kidney stone patients in. And they for over the 20 years, this part of the protocol never changed. They came in, the individuals came in fasting. They got 3 spot urines with matching bloods that were collected. They consumed a breakfast. It was a fixed breakfast that did not change over those 20 years. And then they got timed spot urines with bloods then collected after breakfast up until the lunchtime. After that, the protocol began to iterate with time, but that portion remained the same. So what I did is I took a look at that portion for all the patients who were, I took a look at that portion of the protocol for all the patients who have gone through it. It's also helpful to note that the controls were completely healthy individuals. They didn't have any diagnosed medical problems. And then the kidney stone patients were selected because they were idiopathic hypercalciuric patients, because that's what our group has been many years, decades interested in studying. And so they didn't have any other chronic medical conditions. And so with that being said, what I wanted to do is take a look to see if there were some of these signs of insulin resistance and metabolic syndrome that we could see in them. So you can see here that of the 27 controls, both groups were in their 40s. The controls were slightly younger, more early 40s compared to later 40s for the kidney stone patients. Equal distributions or similar BMIs and equal distributions in terms of sex. Half of the kidney stone patients, half those 42 individuals, had been on a thiazide at some point in their life. Because we know that thiazides are also associated with insulin resistance, I was very conservative in the sense that any kidney stone patient who I saw had ever been on a thiazide, I put them into that group of being on a thiazide. So there's a few of these people who had only been on it for a few weeks. A few people had been on it for years, but it had been a year or so since they'd been back off of it, stopped for a variety of different reasons. And you can see their pressures there as well. Okay. So this data, this is their serum values. I'll go through I'll highlight a few of the individual ones. For each individual, I took the mean in the fasting period and then the mean in the fed period before and after that standard breakfast that was given. And so the first number here is the HOMA-IR, the homeostatic model of insulin assessment of insulin resistance, which is one of the markers among many that one can use for insulin resistance. Less than 1 for this is thought to be normal. 2 to 1 is a little bit of low levels of insulin resistance. And of course, greater than 2 and certainly greater than 3 would be high in terms of more signs of insulin resistance. It's actually a calculated number, I'll say. It's calculated using the fasting insulin and the fasting glucose. But you can see, just looking at the means between the two groups, the kidney stone patients had a much higher HOMA-IR compared with stone formers. When we looked at the individual components of that, then the fasting glucose, fasting insulin, much of this difference in HOMA-IR is probably being driven by the fact that the fasting insulin was much higher in the kidney stone patients compared with the controls. And the glucoses did not quite reach statistical significance. I think that p-value was like 0.045 or something. So, more of a trend towards higher glucoses. That being said, it's in the normal range, right? No one would bat an eye at a 96 in terms of a fasting glucose, but when you look at it, it's sort of trend towards higher than what is seen with the control individuals. But really importantly, in terms of the glucose, though, when you look at the fed period, for that, the individuals who had kidney stones had a much higher serum glucose in the fed period, which means for the exact same breakfast, they had a more dramatic response, a more dramatic increase in their serum glucose levels. So putting these into some multivariate models, then I was able to control for age, sex, and BMI. And you can see here that within that multivariate model, the kidney stone patients continue to have higher insulins and higher HOMA-IRs compared to the non-stone patients in the fasting period, and the glucose also in the fed period remained high. And then to really try to take apart the potential of a drug effect for thiazides, because thiazides are associated with insulin resistance, I did an analysis where I removed all of the 21 people who had ever been exposed to a thiazide. I took them out of it. And so I just kept the 21 who had never been on thiazides for separate models, and the results were really similar. I didn't show them today. I showed the kind of the primary result, which is everyone, but the results were similar. Okay. So what this shows to me is that even though we don't necessarily think about it, right, these patients didn't have any other medical conditions. They were kidney stone patients that didn't have any obvious medical conditions, but they still showed signs of insulin resistance that were greater and worse than what we saw with the controls. And that persisted when we controlled for age and when we controlled for BMI and accounted for thiazide use. So then I wanted to say, is there a larger epidemiologic signal? And so I went back to my favorite cohorts, HPFS and the Nurses' Health Studies 1 and 2. And so, as I show here, and I might have mentioned this before, these cohorts have decades now of data that have been collected on them. So there's a lot of information on these individuals. And what I did is I looked at, for patients who had a history of kidney stones, compared to the non-kidney stone patients, what was their risk of subsequent being diagnosed with diabetes? And you can see here for all three cohorts, the relative risk was about 1.23, 1.23, and 1.35. So all of these individuals had a higher risk of of diabetes if they had a history of kidney stones. But I also wanted to better understand this thiazide effect. I'll say that this model was adjusted for all the dietary factors. It was adjusted for family history of diabetes, family history of stones, osteoporosis. Thiazides are in this model. So there's a whole, because there's a lot of people, I was able to put a lot of things in the model here, and still the finding persisted. Okay, so then I wanted to take apart the thiazide effect. So I did a stratified analysis. And looking first at HPFS, the top one is the group who had been exposed to a thiazide. The bottom is the folks who had not been exposed to thiazides. And you can see here, partially because of case numbers, the case numbers dropped pretty substantially in the thiazide group because there's fewer number of people who had been on thiazides. But actually, in the men, it lost statistical significance in the thiazide group, but the people who had never been exposed to a thiazide still had higher risk of diabetes. And similarly, then for Nurses 1, except for there is significance in the thiazide group here, but the point estimates are about the same, 1.24, 1.22 between these two groups. And when you look at Nurses 2, both thiazides and non-thiazide group has a higher risk of diabetes. In fact, if anything, the point estimate's a little bit higher there in that group. Not that I want you to think that thiazides are protective. Definitely, we do think that thiazides, of course, are associated with higher insulin resistance. But the effect of the fact that our kidney stone patients are at higher risk for diabetes is not an effect that's solely driven by thiazide use. And I'll also say that, because of the tie between uric acid stones and diabetes, I wanted to just highlight that at least 80% of the patients or the participants of these cohorts are calcium-based kidney stone patients. For this study, I don't have stone composition reports for everyone, so I don't know for sure, but in validation studies, that is what has been seen. Okay. So yeah, in terms of so I showed it in the smaller cohort where people were really well characterized. I showed it in an epidemiologic, a much larger study. We still see that our calcium-based patients have signs of insulin resistance, despite accounting for a lot of potential confounding factors. So I don't know what the mechanism is that's driving these two things. I think that some of the hypotheses that we have that I'm currently investigating are things like potentially differences in inflammation, maybe differences in or some being driven by visceral adiposity. We know both inflammation and visceral adiposity are strongly linked to insulin resistance. There's, in terms of kidney stones, a lot of data related to things like waist circumference. So visceral adiposity potentially is increased risk of stones. The inflammation data has been a little bit less clear, but certainly there is some inflammation, local inflammation, if nothing else, for kidney stone patients. And so I don't know the mechanisms, but I do have a study that right now that's ongoing that I think Tuesday we had someone who came in. I think she was like our 36th or 37th person to come through. So we're trying to hit 40, and I think we're obviously quite close. Half of which are calcium kidney stone patients and the rest are controls, where we're collecting all sorts of information in terms of this. So we're getting things like A1C, we'll get all the, fasting insulin and all of that, lipid panel, BMP, and inflammatory markers. They're completing a 24-hour urine collection for us, and we're doing a DEXA. We're measuring visceral adiposity. I have some of the data, but not all of it quite yet. So I don't, unfortunately, I don't have any results to show for that because we're going to do the inflammatory markers in batch, for example. And so I don't have everything quite set, but hopefully quite soon we'll complete the enrollment and be able to then have all the assays and some data to share. Because my hope is that potentially this will help us better understand some of the underlying mechanisms that ideally are maybe even kind of pointing to both directions of the association here. And then also looking at a different hypothesis, but as she mentioned, we're looking, we have a new R01 that's looking at SGLT2 inhibitors. And the hypothesis there is more focused on differences between the two different calcium stone patients and urinary citrate. But we're also going to be collecting at least some of this data to ideally provide some insight in terms of this as well. So in summary, then, this is sort of the highlight of what I was talking about in terms of, we know sugar intake is associated with higher risk of stones, more work to be done on that. And also more work to be done in terms of why our calcium kidney stone patients have earlier signs of metabolic syndrome and insulin resistance than I think is appreciated, which also has obviously, some direct clinical correlations in the sense that since doing this work, I now have a little bit of a lower threshold to really be thinking about risk factor modification from a metabolic syndrome standpoint for my patients who otherwise seem healthy with just calcium-based kidney stones. So with that, I'll say thank you and see if there's any questions.
So much work. So, we count the patients differentially, whether it's, for example, we have more plant protein that we have data on that.
There is a little bit of data on that. Most of it that I know of is more in the epidemiologic realm, but yeah, probably it's a little bit better in terms of plant protein versus animal proteins. Really what we're thinking about is the acid load in terms of some of those differences. I don't know if anyone's looked at the difference in terms of animal versus plant related to the urinary calcium specifically. Definitely with some of the other, lower urinary pH and some of the acid load part of it tends to be a bit better with the non-animal based proteins. There's, usually what I do is sort of encourage more animal based proteins when they can. Most of my patients are not vegetarian. A few of them are though. And then I usually will my recommendations regarding protein then for that is I usually say about one, like I think I said this, but about 1 gram per kilo is usually about a target. It's also, like I said, easy math, although then they have to figure out how many kilos they weigh, but usually that one's at least quicker. But that's how I approach it when people ask me about animal versus plant protein. Yeah.
There's always the question about, let's say, supplements are not actually dietary calcium, but like there's a clear physiology why that.
Yeah. So it's thought that some of the thought is that with calcium supplements, so when you look at that, there was the New England Journal paper from 1993 that was one of the first studies that really looked at this and showed that dietary calcium was protective, but supplements were actually harmful. And the thought was that much of the thought has to do with timing. So if a lot of times, when do people take their supplements? Oh, right after they've brushed their teeth and their supplements are like up in their bathroom. Whereas of course so they're not consuming those supplements often. They're not consuming those supplements at the same time as they're consuming the oxalate. And also it's not, you can pop a pill that has 500 milligrams of calcium. Like I said, you'd have to have a pretty big, decent size of yogurt to get that. So also it's a lot easier to have higher levels of calcium intake when you're utilizing supplements. So those things probably together are why supplements probably increase urinary calcium and risk. So I do have, that being said, I do have some patients who are on calcium supplements. And the reason why is because I have some patients who either, for whatever reason, either they have enteric hyperoxaluria from like IBD. I have a lot of Crohn's disease patients, for example, and some of them have trouble getting, or patients who just lactose intolerance and other reasons can't get adequate dietary calcium. And so, although fortunately for that, there's a lot of non-lactose type of sources of calcium. But still, with that being said, sometimes if I have people who are struggling to get adequate calcium, or if I see their urine oxalates are really high, and I think it's in part because of low calcium intake, I will put them on a calcium supplement. But what I do is one, I start low, but two, I really strongly encourage them to consume it at mealtime. So I actually tell them, do not put this supplement in the bathroom. This supplement belongs in the kitchen, and you consume it at the same time as you're eating your meals. And then we talk about, with bariatric surgery, for example, sometimes they have like lots of small meals throughout the day often. And so we kind of try to strategize with that too. So I individualize it, but usually that's how I approach it. And then, like I said, I'll start with a low dose and then just really follow the 24-hour urines to help guide me. I do make my patients do a lot of 24-hour urines, which is not the most fun, but Litholink has made it very easy to do. And so usually I just then repeat and sort of iterate to try to find that balance in terms of lowering the oxalate and making sure that they're getting enough dietary calcium in. Yeah. But not too much. Mm-hmm. Yeah. Yeah. So, I mean, I share a lot of my patients with endocrinology for our bone. We have a couple people who in endo who do bones. And so we share a lot. And so, because our patients in general, with or without diabetes, are at higher risk for developing osteoporosis and bone fracture. So there's a lot of balance there. I definitely do a little bit of an individualistic goal. If someone's low in terms of their vitamin D, certainly if it's less than 30, I'm going to have them on vitamin D supplements. I don't want them to be vitamin D deficient. Usually for them, for the patients who have osteoporosis, it depends a little bit in terms of what their urinary calcium levels are and what some of their other risk factors for the osteoporosis are. But some of them, I often will have them be on, when I say a calcium intake range, I usually say about 1,000 to 1,200. Usually for the osteoporosis patients, a little bit close. It's on the higher end of that range. And then those are people who I often will have, especially if they're hypercalciuric and if they're already following a low sodium diet. I have a lower threshold for starting a thiazide on those individuals to really lower their urinary calcium as much as possible. And then I also work with the endo team to try to identify, is this person a candidate for either bisphosphonate or some of the other, like Evenity or some of these other bone-directed therapies. So yeah, it definitely becomes a little bit individualistic, but it's very common that this comes up. And I often see on my side, really one of the focuses is as much as possible making sure I can lower their urinary calcium with the strategies that we have, and then really counseling them to make sure that they're getting enough dietary calcium for bone, but not too much, and then working with endo to kind of summarize that. Yeah. Yeah, that's a great question. So oh, sorry. Yeah, thank you. So she's wondering about the GLP-1s, like Ozempic. How is that changing stone risk and incidence and all of that? So the short answer is it's a little too early to know. We haven't necessarily, because, because stones take a while to form, to really see it from an epidemiologic standpoint. It's a little too early to know for sure. My hope, of course, is that my hope is that this helps. I can see a way in which they can help and a way in which they can hurt. So the first, in terms of how it can help, if we can get people to a little bit more optimal body weights for a lot of individuals, hopefully that will help to reduce the risk factor that comes with some of the obesity and diabetes and all of that, which are, again, those are some of the strongest risk factors we have. When you look at the like when you look at the Nurses' Health Study, for example, in terms of diabetes and waist circumference, the multivariate relative risks for like the highest BMIs, for example, are like over 2. Like they're really, really high. So if we can maybe reduce some of that, that would be great. But there is a little bit of a concern in the community because with the diet suppression, there's also suppression of fluid intake drive. So people just don't drink as much. So I have a couple patients who are on them and their urine volumes are really, really low. So we have to really, I've had probably in the last year, maybe like 5 to 10 patients who have been on it. And I see their urine volume is like less than a liter, really quite low. And so with them, and that's really the driving factor because they don't eat much. You sort of see on a 24-hour urine, everything else across the board is low. And so usually what my focus is that we really focus on being very intentional about fluid intake for those, when I see those individuals. So I sort of have to say, I know you don't have a drive to thirst, but we got to try to get you to drink a little bit more. And we talk about strategies to do so. But so we'll kind of see how that plays out. My hope, of course, is that it'll trend towards like maybe after all these decades of the incidence and prevalence going up, maybe we'll finally on the next time start to see it come down. Yeah. So what I've seen clinically is that I said, like, they're not necessarily big difference. Some pH, can't really remember what I've seen clinically. And the other things across the board, they do seem to be lower. There was at least one study that I think it was pretty small. I want to say it was on the order. John, I'm going to look. There was like one study with maybe like 20 to 25 people that without 2. Yeah, but there wasn't really anything remarkable, right? Okay, I just want to make sure I'm not forgetting anything.
Limited because they both studies of people who already had stones.
Yeah.
And so they didn't, the urine chemistry change either study particularly, nor did the urine volume.
Yeah, even to increase their urine volume. Yeah. Yeah. Right. Yeah. So to those of you who didn't hear it, there's 2 studies that have looked at it. It was in stone formers on GLP-1s, and there was not a substantial difference pre and post in terms of the urine composition. But again, the concern about lower urinary volume might be, is complicated for that interpretation because those patients had already been getting active counseling to drink more. So like what I'm doing in clinic. So incident stone formers, a little bit unclear what the effect may be. Yeah. 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 Increase the risk. So a couple of things about the alkaline water. The first is that actually, so what my colleague Anna Zisman one time did a study with her fellows where she got a bunch of waters from some of which claimed to be alkaline water and checked the pH of them. And the truth is that most of those are not actually alkaline. When you do the pH, it doesn't really. So that's the first part of it. The second part of it is that even if it was alkaline, when you drinking the alkaline water does not cause your urine pH to become more alkaline, in part because it gets, you're putting it into an acidic stomach. And so in terms of the changes of what gets absorbed, you don't get I've seen John give me a look. Okay. So usually if you're putting that alkaline water into a stomach that pH is like 2. And so you don't necessarily absorb that as like, even though you're drinking alkaline water, you're not necessarily absorbing more alkali in that setting with these alkaline waters, even if it was a pH of 9. So and actually, John, you did do that study where you looked at the pH of a bunch of different, and the change in urinary pH for a bunch of different fluids. And for the most part, like lemonade and lemon water with lemon, and you didn't see any changes in urinary pH with any of them, correct? No. I don't want to misspeak or misquote you. The fruit juices, yeah. Oh, sure. Low pH, but they alkalize you because they contain organic anions. Sure. The ones that have pHs in the range 3 to 4 tend to be alkalized when you drink them. Did look at alkaline water, published in the Journal of Neurology, and 5 that we studied all had pHs between 9 and 10. Okay, so you found some that actually, yeah, that's good. But they don't have any organic anions. They actually have nothing. I see. They've all been treated by reverse osmosis, so there's nothing in them other than a hint of ions that put back
there's no, you know, if you think about it, a pH of 10 is about 0.1 milliequivalents of alkali.
Mhm.
That's all, and because there's no buffer.
Yeah, yeah, yeah.
You can't provide an alkali. So you're making 70 milliequivalents of acid a day. Knowledge you add 0.1 milliequivalents of alkali.
Doesn't do much. Yeah. Yeah. Did you catch that explanation? Yeah. Yeah. Okay. Just to make sure you could hear. Yeah. I use potassium citrate. You know, if the only time I have a couple of patients who are on calcium citrate, and that's usually related to you know, I'll choose the calcium form when I have reasons to think that they need more calcium in general. And then I try to think about in terms of timing. In terms of like what's more effective, you mean from like a urinary pH alkalinization? I don't think that there's differences in bioavailability in terms of citrate. I'm going to look at John again. In terms of citrate differences there with calcium versus potassium citrate, there's no differences in terms of bioavailability. Correct. Oh, there is. Okay. So then.
So when you take alkali with it, you're always taking alkali with a cation, and it's basically approximately absorbed to the extent that the cation.
Oh, okay. So yeah, yeah.
Almost all our potassium. Then we get 100% absorption.
Okay.
If we only absorb 20% of the calcium,
You're going to absorb a lot less of the alkali. Okay. Okay. So there is difference. So then, yeah. So by that perspective, then, I mean, maybe that's also part of the reason why, yeah, it's much more common for us to use potassium citrate. I can think of 2 people who I know are on calcium citrate in my clinic, and obviously I have many on potassium citrate. Yeah. Yeah. All right. Thank you all.